deals with one of three situations that you're going to be asked to do in preparation for decannulation of the tracheostomy tube. You're going to be asked to cap the end of the tracheostomy tube. You're going to be asked to plug, or asked to plug, or place a speaking valve. So it's one of the three of them that you're going to end up having to utilize. So first let's talk about capping. And with capping, what you want to do again is take care of your patient as far as suctioning the trach. Because I'm going to be deflating the cuff, I need to suction also the upper airway to make sure there's not a lot of mucus that has been accumulated in the back of their throat. I'm going to go ahead then and let me just loosen this a little bit so it's a little bit easier to utilize. I want to go ahead and replace the inner cannula with a fenestrated inner cannula. Okay, so it's a fenestrated tracheostomy tube, and I'm going to put in a fenestrated cuff. Before I do that, I'm going to deflate my cuff. If I had a pilot balloon here, there we go. Remove the inner cannula, maintaining sterility. I have my Sterile Cup here from Tim Hortons. And putting in the fenestrated, making sure it's locked in place. You probably want to hold on to the flange, because you don't want to, when you lock it in place, you don't want the trach to go flying all over the place. Now with the cuff deflated and the fenestration open, I can go ahead and place a cap on there. And because now they're using their upper airway to breathe, I need to place oxygen on the upper airway. If they were on a 40% trach mask, I would need to put a nasal cannula set of what liter flow? 5 liters per minute to generate. Liter flow times 4 plus 20. Okay? So that's capping. That's one method of going through the process of decannulation. We want to verify that that upper airway is patent. There's nothing that's causing any kind of ventilation issues. Second scenario, let me put my inner cannula back in. And again, at any point, if you needed to ventilate that patient, you would need to go ahead and put the inner cannula back in, and then also inflate the cuff and ventilate. So the beauty of this kind of a trach tube is you can alternate between ventilating the patient and being able to go ahead and put some other mechanism there so they can use their upper airway to ventilate. Second scenario is using a plug. Now, a plug is a little bit different from a cap in the sense that when I remove the inner cannula, again after suctioning and all of that stuff and deflating the cuff, this one does not need the other inner cannula. This cap just locks onto the trach tube directly. So where the other one had to go onto the 50mm adapter, this one just goes right into the trach tube itself. Okay, it has the same kind of locking mechanism that our inner cannulas have. Because now they're using their upper airway, I also need to go ahead and put the oxygen on their nose. Okay, or an aerosol mask at 40%, or a venti mask at 40%, whatever. Okay. Cap, plug, and now speaking valve. Speaking valve again has a one-way valve that is there, so that when they draw in, it goes in this way, but when they exhale, it has to go back up through their upper airway. Same idea, I'm going to suction, I'm going to deflate the cuff, suction above and suction below, and in this one I'm going to go ahead and remove and put my fenestrated one in, and then the speaking valve goes on that one. And now because they're drawing in air here, I need to keep the trach mask at that point. Okay, so that's going to be probably the biggest stumbling block, is where do I put the oxygen? Do I put it on their nose, or do I leave it on their trach? Okay. The other mechanisms, or the other way that we can prepare the patient for decannulation, other than a cap, a plug, or a speaking valve, is to use smaller size tracheostomy tubes. So this right now is a 8 fen. So I could go to a 6 fenestrated. And if they tolerate that, go to a 4 fenestrated. If they tolerate that, I can probably decannulate the entire system. Okay. As far as decannulation, again, the whole same process. We're going to go ahead and suction above and below, deflate the cuff. Remove my oxygen, loosen my trach ties, and then while I'm going ahead, having the patient take a deep breath in, I'm going to remove my trach tube. Once that is out, put it in an area where it's not gobbledygook. Go ahead and put a dressing over the top just to keep it clean more than anything else, and place oxygen on my patient. I'm going to make the assumption you know how to put on a nasal cannula. Okay. Rosa nodded her head, so that must mean yes. Okay. And that's basically what the PE is. Again, you don't know if we're going to cap plug or use a speaking valve. So obviously I'm going to practice all three. And you need to know where I'm going to place the oxygen in each scenario. And then the last step will end up being decannulation, where you actually remove the trach tube. I will tell you, if you are at a place like Vibra, you're at a place like Select Specialty, you will take out and replace trachs all the time. Critical care hospitals, not so much. But if you go to a LTAC, that's basically RT's job. So say this trach has been in for a month, it's about time to really swap it out. We'll go ahead and pull the old one out and put a new one in. To put a new one in, all you would need to do is remove the inner cannula, put the obturator in. That stoma is probably going to be pretty patent by this point in time. So it's a pretty easy job to just go ahead and insert the tube back in. Inflate my cuff, and then I'm going to need to put my trach ties back in, just like you did with the other PE, where you have to do trach care. Questions?
We're only getting one for the PE.
I'm sorry?
We're only getting one for the PE.
You'll be getting one of the three for the PE, yes. You should also know about the process of going to smaller sizes also as an alternative.